Hello, and welcome to our Houston Methodist Multi-Modality Imaging Conference. I'm Dipan Shah, Chief of the Division of Cardiovascular Imaging, and with me here today is Dr. Mouaz Al-Mallah, who is our Director of Cardiovascular PET. Today we're going to have the second part in our two-part series touching on the role of cardiac imaging in cardiomyopathies, and today we're going to focus on the restrictive and inflammatory cardiomyopathies. A couple of housekeeping tips before we get started. First, if you have any questions, please feel free to go to pollev.com and enter the word DeBakey with your question, or by text, you can text the word DeBakey to 37607 and enter your message. And hopefully we'll have some time for some questions at the end. So let me go ahead and kick it off with the first part of this lecture, which is going to be the role of cardiac MRI in evaluation of cardiomyopathies. And just to recap from last week, we touched on the role of cardiac MRI for evaluation of some of the inherited and dilated cardiomyopathies. And this week we're going to touch on the inflammatory and the infiltrative restrictive cardiomyopathies. And again, to recap from last week, one of the key principles that we talked about, a unique feature of cardiac MRI, is this ability to directly visualize myocardial fibrosis and myocardial damage. And what we look for is patterns of myocardial damage that would not be consistent with a coronary artery etiology. So for example, in this patient here where there's a mid-wall pattern of enhancement, in this patient here where there's an epicardial pattern of enhancement, or in this patient here who has a much more global subendocardial pattern, which again would not fit with the coronary artery distribution, these are all clues to non-ischemic cause of myocardial damage. And we know from data now that's over 20 years old that all non-ischemic cardiomyopathies are not created equal, and that there really is differential prognosis based on what the underlying etiology of the cardiomyopathy is. So with that, let's go ahead and get started with a clinical case. This is a 44-year-old woman who has no past medical history. She presents to the emergency department with 2 episodes of syncope within the past week. She also notes progressive fatigue and dyspnea for about 6 months, denies any chest pain, PND, or palpitations. Her vital signs, blood pressure is relatively normal, 103/50. Her heart rate is 43, but regular, and has a normal physical exam documented in the ED visit. Her initial electrocardiogram is shown here, and you'll notice that this person has evidence of complete heart block. The P waves and the QRS complexes are completely separate from each other, and the QRSs are going at a much slower rate. Here's the echocardiogram that's performed, and this is done with contrast, which shows normal LV function, although there is a little bit of a hint of an increase in wall thickness here in the basal septum. This person then was referred on for a cardiac MRI, and here's what the CMR, the cine CMR shows that there is in fact evidence of increased wall thickness in the basal septum. We can see that both in the short and long axis views. And you actually notice an area of increased wall thickness here in the apical lateral wall on the 4-chamber view. And in addition to that, the basal portion of the RV also seems to demonstrate some increased wall thickness as well. So clearly, despite the fact that LV ejection fraction is preserved, there are several abnormalities that are noted here in cardiac morphology. And then I think that the real strength of MRI is when you couple that with the delayed enhancement MRI done after gadolinium contrast. And in this patient, we see, in fact, several areas of hyperenhancement. One here in the basal septum. We see another area here in the basal lateral wall. The apical lateral wall, and then we also see an area here in the RV. So all of these areas that I pointed out on the cine that showed an increase in wall thickness all demonstrate areas of hyperenhancement on the CMR. And then T2 weighted imaging in this case was also performed, which also shows in these areas of increased wall thickness and hyperenhancement that there is some increased T2 signal, suggesting in fact that this is an acute process. And then lastly, all of these cardiac MRI studies will also get paired with a anatomic survey of the chest. And you can see here that there's these extensive areas of paratracheal lymphadenopathy. And as we start to come back down, you'll also see in the parahilar region as well that there's increased lymph node sizes. So when you put all of these findings together, the increase in wall thickness, the hyperenhancement on the LGE images, as well as the lymphadenopathy, all of these findings really raise the suspicion for cardiac sarcoidosis. This patient then went on to get endomyocardial biopsy from EP guided within the left ventricle, and in fact the biopsy findings also were consistent with cardiac sarcoidosis. So what's the role of MRI and PET in evaluation of cardiac sarcoidosis? We're going to touch on that today. I'm going to talk about the role of MRI, and here's some data. This is now a study that's almost 12 or 13 years old. One of the unique aspects was this looked at patients with extracardiac sarcoid and just enrolled consecutive patients into this series. So these were not patients that were undergoing a clinically indicated scan, but purely for research purposes, and it allowed the ability to identify what is the prevalence of myocardial damage in patients with extracardiac sarcoid, and also what are the patterns. And you can see, in fact, that the patterns are really quite variable. Here's a patient with subendocardial-based enhancement. Here's a patient with some transmural as well as another patchy area affecting the RV side of the septum. Here's mid-myocardial enhancement. Here's a patient with epicardial septal enhancement that also extends into the right ventricle. And then here's a patient with multiple patchy foci of enhancement on the three-chamber view. And in fact, in this study, while by Japanese Ministry of Health criteria, only about 10% of this cohort would have been diagnosed as having cardiac involvement. Based on CMR, almost 25% of patients had evidence of myocardial damage. Now, a few kind of findings from this study is that one, it occurs in a nonspecific pattern, but it can be patchy and oftentimes multifocal, frequently sparing the subendocardial border. It's commonly seen in the basal segments with a predilection for the septum and the lateral wall. There can occasionally be transmural enhancement, and oftentimes there's also RV free wall enhancement or involvement as well. And let me kind of spin forward a few years from that original study in 2009, and these are the heart rhythm expert consensus statement that was published in 2014, which I think kind of really identifies two pathways for the diagnosis of cardiac sarcoid. One is a histologic pathway where there's myocardial tissue biopsies that demonstrate evidence of non-caseating granuloma. The other is a clinical diagnosis pathway, which is really based on a extracardiac histologic diagnosis, coupled then with some other features which are listed here. And from an imaging standpoint, the ones that I'll point out is a pattern of LGE that's consistent with cardiac sarcoidosis. And Dr. Al-Mallah, I think, will touch on some of the cardiac PET patterns as well that can be seen. And so I think one of the key things, again, is that the current heart rhythm consensus statement really requires some form of histologic diagnosis, either myocardial or extramyocardial, and then you want to couple that with other features that raise the concern for underlying cardiac sarcoidosis. And this is a recent paper from Ron Blankstein and his group at the Brigham, where they went through and described different patterns of LGE amongst a cohort of patients with different pretest likelihood of having sarcoidosis. And so, for patients with possible sarcoidosis, oftentimes there can be one focal area of LGE, but there may be an alternate diagnosis for this pattern of LGE. And then probable sarcoidosis, again, these are the cases where there's a higher index of suspicion, tends to present with multifocal LGE patterns. And it's important, obviously, to then rule out other conditions that could also mimic this. And then highly probable sarcoidosis would really be evidence of multifocal LGE associated also with intense LGE signal, and oftentimes with involvement of the right ventricle as well. From a prognostic standpoint, there's numerous studies, and this is a compilation of several studies, a meta-analysis, which really demonstrated that in patients with known extracardiac sarcoid, the presence of LGE, suggesting that there's myocardial involvement, is associated with a much worse prognosis than for those patients who have extracardiac sarcoid but no evidence of LGE. And so, what is the role for imaging? I think it's really two pathways that we see. So one obviously is in patients that have known extracardiac sarcoid that may get referred to the advanced imaging labs. And this is going to be typically in the setting of either some symptoms, either significant palpitations, pre-syncope or syncope, EKG abnormalities, or some abnormalities on the echocardiogram. And the goal here is really to identify the presence of cardiac involvement. But then there's also a second pathway for patients getting referred for advanced imaging. And these are patients who have no prior history of cardiac sarcoidosis, but who have unexplained advanced heart block, especially under the age of 60. Patients who have VT of unknown etiology, or patients who have heart failure. And in this case, what we're looking for imaging to do is to not only identify the presence of cardiac involvement, but really to suggest, in fact, the diagnosis of sarcoidosis. And then this is a algorithm proposed by Ron Blankstein and his group, really suggesting that kind of a workup pathway for advanced imaging in patients that you have a suspicion of cardiac sarcoid could start with an MRI scan where you look for presence or absence of the characteristic LGE patterns that would be suggestive of probable or highly probable sarcoidosis. And if that's present, then maybe these are patients we would think about considering for ICD, since these patients may have a high arrhythmic risk. On the flip side, if the LGE is negative, then you may be able to exclude cardiac sarcoid unless there's a high index of suspicion, in which case there may be a role for proceeding on to cardiac PET. And then obviously in the patients who do have evidence of LGE by cardiac MRI, there can be a role for cardiac PET here to identify the presence of inflammation. And then I think the PET findings, as Dr. Al-Mallah will touch on, can help you to identify whether there's active inflammation, and this is a patient that may respond to anti-inflammatory therapy. So let's move on to another of the inflammatory conditions, and this is systemic lupus. And again, this is obviously a condition that's not very well studied, but there is this publication in the literature which identified kind of two findings that are seen frequently in patients with systemic lupus. One is that there can be patterns of, again, non-ischemic patterns of LGE or fibrosis in these patients within the left ventricle. And in addition to that, there can oftentimes also be pericardial hyperenhancement as well. And let's move on now to another form of cardiomyopathies, and these are the infiltrative and restrictive cardiomyopathies. And if I show you the cine images here, I think there's several unique things that we notice. One is that there is a small pericardial effusion, and this is the area of increased signal that you see here around the heart. There's also an increase in wall thickness of the LV. In this case, it measured about 1.6 centimeters. There's also increased RV wall thickness as well, measuring about 0.8 centimeters. There's biatrial enlargement that we can appreciate on this 4-chamber view. And the LV function, although not normal, is not significantly depressed. We measured an EF of 47%, so mild left ventricular systolic dysfunction, and mild RV systolic dysfunction as well. And a significant increase in left ventricular mass. But I think, looking at these findings, there's, several different things that could give you this picture right here. But I think when you couple that with the delayed enhancement MRI, which in this case you see, in fact, diffuse enhancement, both of the LV, and also look at the right ventricle as well, which also shows significant contrast enhancement. There's diffuse enhancement of the atrial walls as well, as you can see again on these long axis views. In fact, if we look at the papillary muscles, there's also papillary muscle enhancement as well. These are findings that are very classic for cardiac amyloidosis. And again, this kind of highlights the advantage of coupling the Sinian morphology assessment that you get with MRI with the late gadolinium enhancement that you get on post-contrast imaging. And this is a multi-center study which looked at patients with known extracardiac amyloidosis that presented for a cardiac MRI and really showed that in the absence of hyperenhancement within the heart, the prognosis is much better than in those patients who have known extracardiac amyloid but who have evidence of hyperenhancement detected by cardiac MRI. And this now is a meta-analysis that was just published in the last few years, suggesting in fact that for patients with extracardiac amyloidosis, the presence of cardiac involvement as detected by delayed enhancement MRI is associated with almost a 5-fold higher risk of mortality. And again, what's the underlying mechanism here? And this slide I think kind of highlights it nicely, which is that, you know, in normal state, in normal healthy myocardium, there's very little extracellular space because the myocytes are all nice and tightly packed next to each other. And it's the gadolinium that goes to the extracellular space. So as a result, in normal myocardium, there's really limited volume of distribution for gadolinium. In amyloidosis, though, what happens obviously is that there's an expansion of this extracellular space as there's protein deposition between myocytes. This is what obviously leads to the increase in wall thickness, but also this extracellular space now becomes a larger volume for distribution of gadolinium, and as a result you see hyperenhancement on delayed enhancement MRI imaging. And using this principle, in addition to looking simply for delayed enhancement, there are also now studies that have looked to quantify the magnitude of the extracellular space using T1 mapping techniques by CMR and computing what's called an extracellular volume fraction, i.e. what's the amount of any region that's extra myocyte versus what's the amount that's myocyte. And normal, ECV fractions are on the order of about 25 to 30%, whereas in amyloidosis, you see ECV fractions that are, well into the 40s and 50 or even 60% range. Now let's look at another case. This is a 29-year-old African-American woman who's admitted to the hospital with pneumonia and does complain of some retrosternal chest pain. She has a small enzyme release. Her troponin I peaked at around 2.67 nanograms per milliliter. And if we look at the cine MRI images here, we see that overall LV function appears to be preserved, but there is this area of regionally increased wall thickness that we see here in the anterior wall. You can see that both in the basal short axis views, or also if you look at this two-chamber view down here, you'll notice an area of increased wall thickness. And again, that in of itself could be several different things, but then I think when we couple that with our delayed enhancement MRI, you see, in fact, that this area where we saw increased wall thickness on the cine actually has several components to it. There's the normal myocardium, which is out here in the epicardium, or which is further out, and then there's this area of tissue right here, which has a peripheral rim of contrast enhancement, but a central area of absent contrast uptake. And this is kind of the classic finding that you see in Loeffler's or Loeffler's myocarditis, where there's this kind of inflammatory layer that sits on top of the myocardium, and it's composed really of inflammatory cells as well as thrombotic cells. This patient, in fact, when we looked at her CBC, had a white count of 20,000 with an eosinophilic percent of 67%. Based on this diagnosis of Loeffler's endocarditis, this patient then was treated with 3 months of high-dose steroids as well as anticoagulant therapy, And I have the original cine MRI on top, and then the follow-up MRI 3 months later, and you can see that that area of increased wall thickness in the basal anterior wall has now resolved. And if we look at the delayed enhancement MRI on follow-up, that abnormality that we saw in the anterior wall now has predominantly resolved as well. There may be a small little rim of hyperenhancement in the subendocardium, but most of that thrombotic inflammatory material within the LV cavity has now resolved. Let's look at another condition here, and this is iron overload. And now, over the last, I would say, 25 years or so, there's been a wealth of data kind of highlighting the role of cardiac MRI in assessment of iron overload within the myocardium. And here's just a couple of, or 3 example cases. So here's a patient on the left-hand side, is a 45-year-old who has an idiopathic cardiomyopathy. And in this patient, we can see both in the myocardium as well as in the liver, neither of these areas show a very dark prominence, suggesting that there's not iron overload in these. And I'll show you how now with the newer technique, you can actually quantify the extent of iron. Compare that to this patient in the middle here, a 35-year-old with sickle cell anemia, who in fact has a dark signal both in the myocardium and in the liver, consistent with both hepatic and myocyte iron overload. And then this third patient on the right-hand side who has really just a dark signal within the liver itself, consistent with liver iron overload, but not with myocardial iron overload. And now, the way that we quantify myocardial assessment of iron is using this technique called T2 star imaging. And this is a fairly a straightforward pulse sequence that can be done on pretty much any MRI scanner that has the appropriate software. It doesn't really require high-end hardware to be able to perform this. And it's really performing repeated imaging using different echo times to then be able to come up with a curve of the T2 star decay pattern. And what you'll see is that patients who have increased iron overload will have increased patterns, or will have a faster T2 decay curve, and as a result a lower myocardial T2 star time. And this study right here, I think, kind of highlighted nicely that the optimal time that separates out incidence of heart failure within a year seems to be around 10 milliseconds. And this curve shows that patients who have a myocardial T2 star of more than 10 milliseconds have a fairly good prognosis with a low incidence of incident heart failure, versus as the myocardial T2 star progressively gets lower, there's a progressively higher likelihood of the patient suffering from a heart failure event over the ensuing year. And then this is just some data showing that, in fact, MRI can be used to follow patients that are getting chelation therapy to identify when optimal iron reduction has occurred. And in fact, that reduction in iron load then is also associated with a reverse remodeling of the myocardium, such that there's a reduction in the LV cavity size and an improvement in LV ejection fraction. Okay, and then I think this is when we do imaging, our goals are obviously to make diagnoses, but I think really ultimately is you want to be able to help improve patient prognosis. And I think this slide nicely highlights how in the late 90s, when the T2 star mapping technique came about initially in the United Kingdom, this is showing the significant reduction in the rate of cardiac death due to iron overload amongst thalassemia patients when this imaging technique was incorporated to guide chelation therapy in patients with thalassemias. So again, I think that's kind of the holy grail for imaging, is really to not only diagnose but improve prognosis as well. Let's look at a couple other conditions before we wrap up here. This is a series of patients with Anderson-Fabry disease, where you can see in addition to increased wall thickness that they have patterns of late gadolinium enhancement. And there tends to be a predilection for involvement of the basal infralateral wall, and this is a study now that's almost 20 years old. This study shows here, in fact, the patterns of hypertrophy in these patients, which oftentimes can be global or concentric hyperenhancement pattern, and really patterns of LGE, which again has a predilection for the infralateral wall, but as you can see on the bottom images here, the bottom row, can really affect any region, and therefore it's a multifactorial or multi-variable pattern of enhancement that's seen in these patients. One of the recent things that can be coupled in these patients, in addition to the LGE imaging, is use of T1 mapping to look at native T1 times. And this study, I think, nicely shows that the patients with Anderson-Fabry disease had a lower native T1 time compared to patients with other conditions that can also lead to an increase in wall thickness. And so again, I think there's more data coming out, and this is still, I would say, an evolutionary technique, but I think the kind of tried and true late gadolinium enhancement technique coupled with some of the newer techniques can aid in trying to make diagnosis of Anderson-Fabry disease and separating that from other conditions that also mimic that. And I think that's shown nicely here in this schematic slide, which really shows kind of the relationship of the different forms of cardiomyopathies with native T1 time as well as with extracellular volume fraction. But again, I want to finish off, though, coming back to this slide right here, which really shows the different patterns of delayed enhancement that occur after gadolinium contrast. And again, to point out that, in the setting of ischemic heart disease, you have a subendocardial or transmural pattern, but in the setting of non-ischemic heart disease, there are a variety of different patterns that you have, and there's patterns that will help you to generate a differential diagnosis, whether it's a mid-myocardial, whether it's an epicardial, whether it's an RV predilection site, or if it's a very global subendocardial pattern. Again, all of these are patterns that would not fit a coronary artery distribution, and that's the first clue. And then it's looking at all the other pieces to try to put together what the underlying likely etiology of it is. And I think really it's over the last 20 or 25 years that this late gadolinium enhancement technique has really helped to kind of make cardiac MRI an essential component of the evaluation of patients with cardiomyopathies. And this is the most recent 2019 ACC-AHA appropriate use criteria, which really highlights that there's multiple scenarios where cardiac MRI is considered appropriate or highly appropriate. So with that, I'm going to pause with kind of one final concluding statement, I think, which is that the ability to look at tissue characteristics by LGE and T1 mapping in MRI, I think is really helping us not only from a diagnosis standpoint, identifying prognosis in our patients, but I think most importantly helping to guide therapeutic management and ultimately improve patient outcomes. So thank you for your attention, and I'm going to turn it over now to Dr. Al-Mallah, who will talk to us on the role of cardiac PET.
Thanks, Dipan. That was outstanding. And so I'm tasked to talk primarily about the role of nuclear cardiology in the assessment of these patients with cardiomyopathies. And MRI and echocardiography, as you heard last week and this week, has a great role in the assessment of these patients. And until like the past 7-8 years, nuclear cardiology did not have a seat on the table when discussing these cardiomyopathies. However, there were still some unmet needs that are probably going to be filled by nuclear cardiology techniques, and specifically PET for inflammation and the SPECT PYP for amyloidosis. And this is what I will cover for my talk. So I'll start where Dipan finished, which is primarily the late gadolinium enhancement of a patient that clearly looks like sarcoidosis. And when you see someone like this, if the patient is asymptomatic and you want to know if this is representing a prior inflammation or this is active inflammation, it depends on the patient's symptomatology, but PET, specifically inflammation imaging, may add to this assessment of these patients to help tailor their therapy and follow-up for these patients. So how do we do that? I think I want to just clarify a few things about the protocol itself, not to educate, to mention like how you're going to do it, but more to put some realistic expectations when you order these studies, because these studies will require some preparation, because we're injecting FTG for these patients, which is fluorodeoxyglucose, and then the patient, if we inject it like immediately after a meal or without any preparation, all the myocytes will take the FTG and the entire heart will light up. However, we need to have some preparation where we provide the myocytes with enough free fatty acid, so when the FTG goes in, it will go primarily to the inflammatory cells. And the preparation protocol has been like under evolution, and there are many studies that are ongoing trying to simplify it, but the idea here is that it requires at least 24 hours, sometimes even 48 hours to do the suppression of myocardial FTG uptake. So the day before, or sometimes we ask patients to do it even 48 hours before, we want the patient not to have any glucose. So they have to have no carbohydrate diet, they need to fast for 12 hours, and this is kind of a sample of what they can eat. So no carbohydrate, no breaded chicken, no high fruit or others. On the day of test, we ask them not to exercise. When they come to us, we do perfusion imaging. Then we give them heparin if they're not on oral anticoagulants. Then we go ahead, wait for 15 minutes, inject our FTG, wait another 60 minutes, and then inject the FTG, image the FTG, and then we have the images for both perfusion and metabolism to kind of help us interpret these studies and guide us in the assessment of these patients. So I'll start by showing you a normal study. So if our protocol worked and we suppressed the myocardium, you can see here where my mouse, hopefully I can get my mouse there, yep. So you can see that there is a septum, you see the apex, lateral wall, so all of them are suppressed. There is no FTG in there, and the FTG is all sitting just in the blood pool, and this is a normal study. So blood pool in the FTG in the blood pool, and no uptake in the myocardium. You see the same thing in the right ventricle. And if we do it with our description, that our display in nuclear cardiology, you see on the top row is the perfusion images, and then on the lower row you see the FTG images, and you see the myocardium without any FTG uptake on different cuts and different views. Now, if there is FTG uptake, now it's going to go to the myocardium. And here's an example of a patient that has a resting perfusion defect. So you can see that there is a perfusion defect in the basal anteroseptum, the entire septum, and also in the inferolateral wall here. And now there is FTG uptake in this same area. Now, if there is a perfusion defect, that might mean that this is a prior scar from a prior affection. Doesn't always mean that there is active inflammation. Now, in that area of that perfusion defect, now I see there is uptake of FTG, and that's probably the most specific pattern that we see here. Now, you can see here also on the basal wall, there are some areas of perfusion defect that does not have FTG, and these may represent some prior scarring. And you can see here also, like in another projection, where we see the septum is like kind of cut it short, and here it's continuing in the FTG images. So if you combine them, you get like the entire heart picture. So this is how we see it. We can also look at it in the fused images, and we can see that if there is uptake outside the left ventricle, in this patient, for example, there was intense FTG uptake in the left atrium. And that is also another sign. And this patient in specific was having a lot of inappropriate ICD shocks from atrial arrhythmias, and this correlated with actually significant FTG uptake in the left atrium. since we have the ability to look also at other organs, we can see FTG uptake if there is active sarcoidosis outside the heart, like in this patient, where they have a very bad aggressive pulmonary involvement, and this could be concerning for cancer, obviously, but this turned out to be sarcoid in this case. We can also look for mediastinal lymph nodes. You can see them in this nice case where there is significant multiple lymph nodes on both sides, and significant FTG uptake that you see here in addition to cardiac. So how do we put it all together, and what are the potential patterns that we see? So the first one is the normal that I just showed you in the beginning. However, there are sometimes the patient don't follow the diet, or they just fail. I mean, they do follow it, and we have recently a patient that followed the diet 3 times, and he insisted that he followed the diet, but we still could not suppress the myocardium. It's not common though. I mean, out of the maybe 300, 400 studies, we have very few, less than a handful, that we just could not suppress them. And here's one example where you see this patient had a normal MRI, normal perfusion, and you see we have diffuse homogeneous FTG uptake on 2 studies, and the patient significantly told us that he followed the diet and there was no, he did not have any carbohydrates. So, and at this time we're still having, we're investigating other potential tools to help us identify those that we did not achieve appropriate free fatty acid in the blood, so that the study is still non-diagnostic. Unfortunately, at this time, nothing has been guideline recommended to help guide us. We have to put it all together to kind of identify those that fail versus those who have had the good study. Here's another example. For example, I'll show you a patient again where you see a perfusion defect. So this is very concerning. I mean, the anterior septum, there is some perfusion defect. But then you look at the FTG, I mean, it's homogeneously uptake except in the inferolateral wall. So we were not too convinced that this might be true, and we told the patient to have longer diet follow-up. And you can see here that on repeat, there is now the same perfusion pattern, but clearly no FTG uptake that you can identify easily. Maybe this one is mildly abnormal at that stage in the basal anterior wall, but nothing as much as you can see in terms of the first study. And this is very important because we don't want to give these patients a diagnosis that will require long-term therapies with multiple side effects of these medications and will have devastating effects on these patients. Now, how are the positive studies looking like? So the focal increase with the mismatch pattern, like the first case I showed you, that would be the best kind of example and the most specific. And that one where you can see a perfusion defect and there is FTG uptake in that territory. Sometimes there is like focal, but it is diffuse, but it's also following a peripheral defect. And there is focal area, but it is in a different area. And sometimes even though there is normal perfusion in that segment, but then you still have some FTG uptake in that area. If we see these 2 patterns, the top one, then we are pretty sure that this is the pattern that is, patient has active inflammation. We also couple that with reading evaluation of the MRI at the same side, and Dr. Shah showed before the slide where it showed how we can potentially combine them. Now, there's always an intention to do biopsy for this and try to identify what's a primary pathology, because remember, FTG, like late gadolinium enhancement, are not specific for the disease. It is more for inflammation. And there have been multiple patterns of inflammation that could give you FTG uptake, and that's why sometimes we do need a tissue biopsy, whether it's cardiac or non-cardiac, that's a different story, to identify the final diagnosis. In this patient, for example, he had multiple biopsies. All of them came non-specific, but this pattern, we were sure that this is a very specific pattern for cardiac sarcoidosis. And this patient, lucky, after like 2 studies with us and been following him, he underwent heart transplant, and on the explant, it was the time that they identified this non-caseating granuloma, which actually made the diagnosis of cardiac sarcoidosis, despite multiple cardiac biopsies before that were negative for cardiac sarcoidosis. Recently, we even had a study where the LV, there were some uptake here. It's mild uptake though, but we also noted uptake in the atrium. And in fact, the LV biopsies, the electrophysiologist did 7 biopsies from the LV and 1 from the atrium. And you see the pathology report here. The right atrial, the septum, turned out to be positive, while the 8 biopsies from the LV were actually negative for sarcoidosis, which tells you about the difficulty of establishing the diagnosis based on cardiac biopsy, because many of these patients have potentially either diffuse fibrosis from multiple attacks or very patchy disease that you may not be able, especially if your biopsy is blinded on the RV side of these patients. We know that FDG uptake, based on this study, FDG uptake and a perfusion defect carries worse prognosis. We recently published a meta-analysis of only 5 studies that have reported on that. The main limitation of this body of literature is that it's primarily, the meta-analysis did not exceed 250 patients in 5 studies, small sample size, and multiple heterogeneity in the endpoints. But this is kind of the best available evidence for these to predict outcomes. And it does correlate very well with MRI, and Dipan has mentioned that before. Dr. Shah, looking at this patient, for example, who had a cardiac arrest in an emergency room, he has late gadolinium enhancement in multiple spots. You can see focal FDG uptake in these same areas, although in some areas the extent of FDG uptake was a little bit more pronounced, and especially in the inferior wall and inferior septum. And you can see the areas here. So we always, when we're looking at to establish a diagnosis of cardiac sarcoidosis, we're always looking at both modalities, CMR and PET, and we prefer, as mentioned before, to always start with the CMR, because if there is late gadolinium enhancement, you establish the diagnosis, but now you want to know if it's active or not. Then you can potentially go for PET. There are very few cases where you may potentially have a negative CMR, but then have high index of suspicion, and then you may undergo a PET. And we have only 1 case of that, and this is a PET scan of that patient where there is significant FDG uptake. This is a patient, young patient, who came in with complete heart block, and the CMR did not show any LGE, but there is significant FDG uptake just at the basal septum in this case. And this is kind of the classic example where potentially you might have a normal CMR in a case of a high index of suspicion. Now, the amount of inflammation may not be the entire area that you see here, but it's primarily smaller, but because of the amount of FDG uptake, then it might appear to be a little bit bigger. I think the biggest advantage of PET is that once you establish the diagnosis by MRI and you see if there is disease activity, you want to follow these patients and you want to see if there is improvement after therapy. And this is where it's an important unmet need with other imaging modalities. You can see here that this is a patient who has significant FDG uptake, 3 months of steroid therapy. Now it's all gone, and it's all now in the blood pool. This is black and white, and this is colored, and you can see here 3 months of therapy, and the patient had normal. I would say 3 to 6 months has been our average. Sometimes it may not completely go away by 3 months. And you can see here in different views also the uptake in the septum is almost gone to a nil, and there is no uptake. And also we're investigating how to kind of assess response, because we don't always have complete recovery where it's like completely gone from normal to just a blood pool, but rather sometimes we do have some some reduction in inflammation, and which parameters you take for that. So this is, for example, a patient who had multiple MRIs with multiple PET scans with us. You can see initially the area of inflammation is this green, red, and the different areas, and these are color coded by the amount of FTG that's uptaken, and her SUV max is 8.4. After 4 months of prednisone and CellCept, yes, it didn't completely go away. There's still uptake, but you can see the area or the volume of inflammation has significantly decreased. Although in the remnant area, it's still very hot, and the difference was only dropped down from 8.4 to 7. So you might argue that if you're going to look at it from an SUV max kind of point, it may not have like gone completely, but the volume of inflammation has significantly dropped, and the patient ejection fraction has also improved. We can also look not only at the impact on the heart. So this is, for example, a patient who has cardiac and extracardiac FTG uptake. You see all these lymph nodes that are lighting up. In fact, if I might argue that the extracardiac are probably way more intense in this case. Now, after therapy, you can see now we have a blood pool in the post-therapy, and there is significant improvement in the what we see in the chest, although it's not completely resolved. So complete resolution of cardiac inflammation, but partial resolution of the inflammation in the mediastinum. I just want to tell you that also we're starting to see these and other, not only the left ventricle or left atrium. This is a patient who has clearly late gadolinium enhancement in the pericardium, and there was a concern whether there is also myocarditis and myocardial involvement. And we did an FTG PET, and we don't see any uptake in the myocardium, but it's only in that area of significant inflammation of LGE. Still MRI is leading there, but sometimes you have to pay attention to this and look at the pericardial FTG. And as a segue to the other cases, sometimes we are seeing some cases where there is just very mild inflammation. So we are primarily detecting inflammation. We have one case where we had just minor inflammation. You might argue that we didn't even suppress the blood pool because there is just minor FTG. And this is actually not our case, but this is a case just published 2 days ago in the Journal of Nuclear Cardiology from Mayo Clinic, where they showed that this case turned out to be amyloidosis. So our case also turned out to be amyloidosis by biopsy, which makes me wonder whether amyloidosis is associated with a low-grade inflammation in the myocardium. So this is kind of not FTG uptake in the myocardium. It's sarcoid. Keep in mind some of these low-grade inflammation may turn out to be amyloid. We have an unequal one, and in this case series they published 5 cases that have that. So this is a good segue for amyloidosis, and Dr. Shah mentioned about the different patterns that you see with amyloidosis and MRI. This is one patient that has thick biventricular hypertrophy, and the annulus is not moving, mitral annulus, significant MR, atrial dilatation, and you can look at the late gadolinium enhancement and you have difficulty nulling the myocardium. So this is like already established the diagnosis of amyloidosis, and now the question is, how are we going to treat it? Is this an ATTR amyloidosis, transthyretin amyloidosis, or this is AL amyloidosis? And this is where PYP imaging comes into play. So PYP imaging is not going to come into play until the either highly suspicious MRI or echo. And this is where PYP comes into play, because we're trying mainly not to establish a diagnosis of amyloidosis, but differentiate the subtypes of amyloidosis from ATTR amyloidosis and AL amyloidosis. And PYP is a bone scan. It has been it has been used for a long time in the US, and it was even used for cardiac imaging many years ago for the detection of acute MI. Now it's not being used for that, but primarily used for bone imaging and bone scanning. And this test is simple. You don't need any contraindication. You just need the patient to lie on their back for 30 minutes and have an IV access, inject the PYP, wait 1 hour and image them. And you get different examples based on what you see. And this whole field few years ago started with planar imaging. So think of it like a chest x-ray. So what we are doing, a chest x-ray, the heart should be at that point. Here there is no uptake. There is mild uptake here but less than the sternum. Here there is uptake but equal to the sternum. Here there is uptake in the heart but more than the sternum. So we call them grade 0, 1, 2 and 3. And this is primarily qualitative based on the planar imaging, which is the equivalent to your chest x-ray. And later on, to be more sophisticated, and people started to draw an ROI, get the activity here, draw another ROI, and then get the ratio. And if the ratio is more than 1.5, it was suggested that this is going to be highly sensitive and specific for amyloidosis. In fact, a meta-analysis of 6 studies looking at 529 patients showed a very high sensitivity and very high specificity, above 90%, for detection of AL amyloidosis in these patients. And it does have prognostic information above 1.6. So those who have a ratio above 1.6 have worse outcome compared to those with less than 1.6 heart to contralateral lung ratio. The problem is started when this started to infiltrate into the community, and now you have patients like this, and you may not be sure if this is purely coming from the muscle or coming from the blood pool. And I'll show you some examples through here. So this is where SPECT imaging is coming to suggest. So think of SPECT imaging here playing the role of CT, and trying, instead of chest x-ray, I want to look at the heart in CT. So I'm looking at it in tomography and trying to look at the heart, and I want to make sure that the uptake is in the myocardium. So this is SPECT. We took it even further step and did it with SPECT CT, because we want to make sure that the uptake is coming, like for example here, in the muscle itself, in the septum and in the basolateral wall. If you look here, why we prefer CT, because we want to avoid overlap with bone uptake. We want to distinguish blood pool activity from myocardium. That's an extremely important reason, and that's probably the main reason of false positive studies that have been described. And look at the distribution of myocardial PYP uptake. And if you want to do biopsy, then it will guide you to see how much uptake in the septum, to guide the interventionalist doing the septum, and also try to quantify the myocardial uptake compared to the rib uptake. So here are some examples. Here's the ratio at 1 hour is 1.5, and now you see that this is the uptake is all in the blood pool. So I don't see any myocardial uptake. So even though I have a ratio of